Hi, everybody. Susan Clinton. This is podcast number 186. And in this podcast today, we're going to be talking about the connections of the diaphragm with GI dysfunction as well as chronic low back pain. And we have solid evidence that chronic low back pain and GI dysfunction go hand in hand. There's been countless research done on this, and there's been all kinds of newer information coming out about it may not be causing each other, but they're certainly highly correlative. And it's incumbent upon us as therapists to look at the whole system and not just single out a certain system or a region. And hopefully this will shed some more light on things that can help with your chronic low back pain patients or your patients who have chronic GI problems. They probably have chronic low back problems too. So enjoy the podcast and let us know what you think. Hi, everyone. It's Susan Clinton along with my fabulous co-host, Erica Mello. How are you today, Erica?
I'm fine, Susan. How are you?
I'm well, thank you. And today we decided that we were going to just sit down and talk about just making some clinical correlations. And one of the ones that I wanted to just kind of toss around a little bit and discuss is the role of the diaphragm and how it has got how we know what the diaphragm's supposed to do. It's a breathing muscle. There's no question about it. It is, but it's also a primary mover of the abdominal contents. As it presses down and lifts up. It's like a mechanical sump pump that pushes the organs down and then lifts them up and pulls them back up again. So the organs move beautifully with the various respiratory requirements of the diaphragm. It also helps us move things out of our airway. So we have to cough, we have to sneeze, we have to clear the airway, and it allows that to happen for us. And finally, it can work as a postural control muscle because when we hold our breath or cut off our glottis, the diaphragm doesn't move. And that provides probably the most stable stiffness for the entire trunk of anything else. Because when you do that, if the diaphragm doesn't move, the pelvic floor doesn't move, the abdominal contents, the abdominal wall is stiffens. And so you get this great stiffness of the spine. And so when we're working under really high 1 rep type of max situations, we have to hold our breath. It's a primary neural reflex pattern that allows us to do something a little bit beyond our capacity.
Yeah. And also, Susan, when people, when you lie supine, right? And if you have issues in your GI system or abdominal viscera, when you lie on your back, a lot of those contents shove up against the diaphragm, right? And the diaphragm, I believe, is phrenic nerve. So you could get all sorts of like shoulder symptoms just with some basic, just lying on your back. And the reason I mentioned that is because I have a patient right now who we'll talk about at some other point, who's her only issue is when she lies on her back. And so you think about what happens to the systems when you're in supine, and especially when you're have GI dysfunction, and who doesn't have GI dysfunction? And it could be that most people do at some point in their lives. A lot of people have normalized it and they don't even mention it. You have to ask for it. Ask about. I'm pointing into the screen. I'm like, you have, right? We have to ask about it because they've normalized it, right?
And they've normalized back pain, so they come in with GI dysfunction and are complaining about that, and don't tell you about the 20 to 30 years of chronic low back pain they've been, dealing with as well. So it's interesting because you bring up them laying on their back and the abdominal contents moving upward, cephalad towards the head, and how that does begin to change things like the length-tension relationship of the phrenic nerve, or maybe makes it more hyperexcitable because the diaphragm has to work differently to push, for breathing. And so we do bring in other accessory breathing muscles that we don't need when we're laying down. It's one thing that to use those accessory muscles when we're up and we're running or walking or, kind of moving along and lifting and pulling things and doing stuff. When we're laying down, we shouldn't be using anything other than what we just need for that homeostasis there. So we don't need hyper recruitment of lumbar spine muscles. We don't need hyper recruitment of pelvic floor muscles or hip muscles, deep hip muscles. We don't need chronic recruitment of the upper abdominal region. We certainly don't need hyper recruitment of muscles around the neck. Not in a laying down position supported.
No.
We should be able to turn things off when we do that. The interesting thing that you brought up with laying down is it's going to bring me to my next point is that over time and under certain conditions, the diaphragm becomes recruited as a postural control muscle. And so now it's in the position of where it's not doing its job as the primary respiratory muscle. It's having to do double duty. It's having to help stiffen the spine, but it also, and that takes away from its ability to be a great respiratory muscle. So we end up with people with chronic low back pain or chronic GI problems, and we know this about these two populations, which they go hand in hand, is they have a lower heart rate variability. They have decreased endurance, and they have limited capacity. And we know that. I mean, somebody with low back pain can still move and walk, but the pain has inhibited certain muscles. So we think about in the face of low back pain, the multifidi get inhibited. And the multifidi are really responsible for really helping, create that dynamic bridge that the spine really is, that can move, and shift and turn and rotate and side bend. And when those muscles are inhibited, the other muscles, the rector spinae muscles, are kind of recruited. And all they do is bring that bridge into compression because the lumbar extensor muscles are designed to lengthen with forward flexion and pull you back up out of forward flexion. They have a role. They're supposed to do that, but they're long axis muscles. They're not short muscles in between. The interesting thing too is that in the face of pain, with low back pain, the abdominal muscles, or sometimes certain abdominal muscles, are definitely inhibited.
Yes.
Some might be over recruited. I mean, if the people who get real specific with, real-time ultrasound will tell you, oh, the obturator externus or internus gets over recruited, and some things like that. But basically, what happens is the abdominal wall isn't functioning like it should to help stiffen the spine, and to help with the other things.
And also you want to think about, what's the real impairment, right? So when you have somebody who's coming in to see you for whatever reason, let's say back pain, right? Or pelvic girdle pain, and they do have a deficient, quote unquote, abdominal wall, is it because, their rectus or their obliques or their lumbar paraspinals are overactive, thus inhibiting choices for movement or choices for muscle recruitment? Or is there truly like a strength deficit? In my population, I don't tend to see like the postpartum, or it is an overactive system first that needs to get sort of down trained. And it does, we talked about this earlier before we got on about stiffness, right? And so is the thorax really stiff? Generally not from a joint perspective. Okay. This is my belief. It is an accumulation of muscle recruitments in and around the thoracolumbar spine that give that appearance of stiffness, unless there was a subluxation of some sort, like a trauma. It's that muscular, the diaphragm, all those muscles surrounding, especially the abdominal wall, that tend to air quotes stiffen it. But it what's the word, Susan? It's giving the patient fewer options for movement and muscle recruitment, right?
Yes, 100%. And I think that when we look at that and we add that up to, thinking about GI dysfunction, there's all kinds of GI dysfunction diagnoses, but basically when we talk about chronic GI mostly we're talking about irritable bowel or, inflammatory bowel disease is another whole story.
Mm-hmm.
But irritable bowel or chronic constipation, which always leads to some sort of general discomfort.
Mm-hmm.
And when we have irritable bowel constipation or irritable bowel, even diarrheal or mixed, or we have chronic constipation, the client has an abnormal sensitization or response. It's almost like an allogenic response to normal gas and normal stretch of the lumen in the GI system.
Mm-hmm.
So when that happens, they feel like that they're really bloated. And in many cases, when we get into this chronic era, like we're talking about with chronic low back pain, chronic GI dysfunction, there definitely is a measurable distension that goes on.
Mm-hmm.
And
Mm-hmm.
it's very, very interesting because we can compare a couple of research articles here in just a minute. But it's interesting because what happens when we have that allogenic response to normal gas, gas is normal,
Yeah.
rapidly bringing liquid into the stool is normal. But for these people, it feels terrible.
Yeah.
And so that pain that they have, that's the visceral kind of pain, actually inhibits the abdominal wall. And so the abdominal
Ah, right.
moves away from the pain, which makes sense. It's like, well, typhoid gets inhibited and it doesn't, so, but the interesting thing is now the body is being put in a position where it's really hard to move the gas or the stuff through, maybe
Yep.
even stool when it's time to go to the bathroom,
Mm-hmm.
because
Mm-hmm.
the abdominal wall is being inhibited. And when that happens, the diaphragm has to become a postural control muscle. It is no
Yes. Yeah.
longer free to move because something has to hold the spine together.
Right.
Right? And that's just
Right.
what happens. And so it looks the
Yes.
same as like with a chronic low back situation.
Yeah.
So they develop many of the same characteristics, which is interesting.
Yeah, it's almost like, okay, your first two choices or your first choices for muscle recruitment, for postural control, have been ruled out because or have been inhibited because of the GI and the chronic constipation. So what's left? The trusty diaphragm. And then then you'll go down that whole rabbit hole of, okay, what am I gonna do? I'm gonna brace. I'm gonna brace, right? That's what we do. We brace, right? And it will give the appearance of, a stiff thorax, it could be a stiff anything, to be quite honest with you. I mean, that's how broad. But you want to think about just the what was I reading? For those of you who don't know, I'm in the process of doing my doctorate, and I'm deep diving into this differential diagnosis course right now. And I was reading something about where I'm just drawing a blank here about the parasympathetic and sympathetic innervation into the abdominal wall via like the vagus nerve and the phrenic nerve for the diaphragm. And I'm reading that, and I was like, there's got to be a play here in terms of treatment
Yes,
for okay.
there
It's a
is.
a
I'm glad you
nice
brought that up
segue.
because your explanation of that is definitely the underpinning, the neurophysiological underpinning of abdominophrenic dyssynergia. And that's what we're talking about here. For those who live in the pelvic health world, they understand pelvic floor dyssynergia, which is, and when the rectum gets the message that there's stool there, the pressure system increases in the rectum, and the stool moves down towards the anal verge, they have a concomitant closure of the EAS. It's reflexive, and it's wrong. That's not what's supposed to happen. What's supposed to happen is the AAS is supposed to soften and relax with interrectal pressure so that we can push the stool out, right? But no matter what, and it's under voluntary control, but for whatever reason in dyssynergia, that neural reflex is switched. And so it becomes hard and it won't let go. And it requires all kinds of things, to push and push and push to push it out. And there's many, causes for that. But what we're talking about today is we're talking about the abdominophrenic dyssynergia that I think we see in the face of chronic low back pain as well as GI dysfunction. And so what happens is like we talked about, the abdominal wall softens. That's vagus input, like relax, pull away, do that kind of stuff because the gas is so uncomfortable. It's almost it's almost a parasympathetic response that's gone wrong. It's gone over the end.
Mm.
Instead of being the quieting, calming, it's now the like makes you nauseous, make you
Yes.
feel
Yes.
bad.
It's like an autonomic response.
Yeah,
Yeah.
exactly. It's that bad autonomic response because the
Yeah.
sympathetics are so high, it has to raise up to that level to meet them.
Yes.
But anyway, the diaphragm tightens, it thins. I mean, it stays, it stays tight, it stays recruited. And the ventral part of the diaphragm, if you think about the ventral part, is the part that's near the spine, where the esophagus and the aorta and the vena cava and the vagus nerve and all the other nerves and everything else all come through, the lymphatics, everything come through that hole in the diaphragm there,
Yep.
which is ventral to the central tendon. And
Mm-hmm.
so what happens is that diaphragm lifts up and pulls back towards the spine.
Mm-hmm.
And it kind of, when it does that, it makes it kind of be flattened. So it's like
Mm-hmm.
steep on one end, but the rest of the diaphragm is flattened down because of the
Mm-hmm.
link tension relationship. And they displayed this beautifully in the 2012 Kohler article, where they had
Oh,
people,
right.
all things, laying on their back because they were doing
Mm-hmm.
functional MRI and looking at they looked at tidal volume of the diaphragm under people without pain or problems. With,
Mm-hmm.
the other group was people with chronic low back pain. They didn't even talk about abdominal stuff. I mean, GI stuff. And they basically looked at them laying still and doing regular breathing. And then they looked at what they called, they gave input to increase the force volume. So in other words, they pushed at their knee and told them to resist it.
Mm-hmm.
The knee
Mm-hmm.
was pushing up against their hand.
Yeah.
And then they looked at what the diaphragm was doing, and they did the same thing with the arms. Kind of at the
Okay.
forearm, they would put pressure and tell them to push up against it. And what
Mm-hmm.
they found both during the force, both diaphragms tended to track ventrally a little bit to
Mm.
assist. But
Yeah.
the biggest change was in the people with back pain. Because what they
Okay.
found was, even with normal laying still, when you talked about this, laying on their
Mm-hmm.
back, that diaphragm should be relaxed and breathing beautifully.
Mm-hmm.
They found that their diaphragm was thicker, less like recruited. When you look at pictures of recruitment and MRI, you can see the different things. If you look at the
Yeah.
article,
It lights up. Yeah.
um, but basically, the diaphragm did not have the same movement in for just rested tidal volume for people with low back pain compared to people without.
So
So
at
there's one.
rest.
Yeah, at rest, it was
Got it.
already behaving in an abnormal way. It was
Right.
behaving like it was working too hard. And
Mm-hmm.
then under the force volume, when they put the pressure on, it
Pressure.
even
Yep.
got even more. The ventral side slipped up even more compared
Mm.
to the normals, and it was
Mm-hmm.
really, really very interesting to look at, because when you take that 180 degrees and go forward into the GI system, they've done a lot of studies using ultrasound and looking at what's happening to the diaphragm and to the abdominal wall in the face of gas. And one of the
Mm-hmm.
things that they looked at in one of the articles, and we'll put these articles, I'll put the links to the articles in the show notes so everybody can read them for themselves. There's 3.
Mm-hmm.
There's the Kohler article and the 2 articles on this abdominal phrenic dyssynergia explained
Mm.
finally. But the biggest thing that they found was, when they put gas into people, they introduced colonic gas into the 2 groups, one with, chronic constipation and one with, no problems, no GI problems.
Mm-hmm. Mm-hmm.
And when they introduced the gas into the people without issues, their abdominal wall tightens and their diaphragm lifts up and is free to move.
Yes.
And that's
Beautiful
important,
movement.
because think
Yeah.
about this. The diaphragm is the handle, the pump that's going to push the gas out. And
Right.
so we have to have a tightening of the canister and the diaphragm
Yes.
movement for the gas to move through. That's how we get
Yes.
out of our body.
Right.
And it's normal.
Right.
So when we do it, but when they did it to the people with the chronic GI problems, their abdominal wall did not tighten up in response. In fact, it distended.
Oh, interesting.
Yeah.
So how do they get the
and that's
gas out?
Yeah. So yeah, exactly. How do they get the gas out?
Right.
Because now they're in a disadvantage. Now they don't have
Right.
any, the wall is softening. The diaphragm is what they call descending in this article, but basically it just means that it's pulling back ventrally and flattening out. And it's
Yeah.
not free to move, because now
Right.
it's having to take over to work with the spine, because the abdominal wall's being inhibited.
Yeah.
There's something in our brain is going to say, don't let your back fall apart. We got
Right.
to have some muscles working around there, right? Muscles are
Hmm.
what moves bones. So if something isn't doing what it's supposed to do, something else has to do it, or he's going to
Yes.
try.
Right.
And it's,
Right.
it's a fascinating kind of thing to look at when you see those two things together, because it's like looking at one or the other, but they're kind of the same mechanism that's at work here.
Yeah,
And
that's
it
interesting.
makes it
It-
very
it-
interesting to see the difference there, and how important the linchpin is the diaphragm. It's
yeah,
like
yeah,
what's
because
happening.
because if it doesn't, if it's not being called upon, or not, I take that back. If it's not, like, imagine a starting line. The people who have this GI dysfunction, they're not even at the starting line. They
Right.
have so much more to go to get to that starting line. So even to push the gas out or to push anything out, they're at a
Mhm.
disadvantage. So they're going to recruit all sorts of accessory muscles, and they may get away with that for a period of time, but ultimately it will manifest in some way. It may not manifest in pain. It may manifest in another way,
Mhm.
especially with the diaphragm, because it is such a. I mean, anybody. I mean, seriously, people, when you're listening to this, look at an anatomy book,
Yeah.
because I think it'll really help when you actually see what we're talking about. I'm a visual learner myself, and seeing, for my course I'm taking for my doctorate, just seeing pictures and realizing how everything is connected. We talk about how the foot's connected to the knee and the knee's connected to the hip. Well, all the viscera are connected. People, they all are, and they attached in very close proximity to the diaphragm, which is in the thorax, and the thorax sits to the head. And I'm almost wondering, did they, in any of these articles, did they treat these people, or did they suggest, any treatment options?
So we know most of the treatment options for chronic low back pain is to see if you can get the multifidi back on board, see if you
Mm-hmm.
can, get the abdominal wall working in much more of a coordinated way, which is why we don't like abdominal bracing as much, because we don't want to do the opposite, which is over recruit the abdominal wall. But here's the thing. One of the things that we can do if we want to look at this in both populations, because they probably have this distension if they've got chronic low back pain. So just know that, which is why we're
Mm-hmm.
talking about this today, because these two systems are very interrelated. Here's the way that they talk about in the articles about using some biofeedback to help recruit the abdominal wall, and to get it going a little bit better. But these people are in pain, so I've kind of taken that and turned it into a different type of intervention. And it'll be interesting to see what you think with the person that you were thinking of that's having this issue that you're seeing now in the
Mm-hmm.
clinic.
Yeah.
My progression is as follows. I get people to get inverted first. So either leaning over a countertop, or on hands and knees if they can tolerate hands and knees.
Mm-hmm.
Just hands, not everybody can.
Mm-hmm.
What I want them to do is it's going to sound a little backwards, but it's important, because if you think about muscles that are long, they have created sarcomeres in parallel along the length of the muscle, right?
Mm-hmm.
And muscles
Mm-hmm.
that are short have a lot of sarcomeres in series where they, can contract easier. So these people with these softening walls, because of this chronic distension that goes on every time some gas enters into their system, usually by the end of the day, closer to the afternoon, evening, always more, because that just is how it works. It's the pattern that I've seen over and over again. What I do is I get them to really let go of their abdominal wall all the way. Okay,
Mm-hmm.
yes, that's feeding into the problem. Is the abdominal wall's too soft. However, I've got to get the right muscle tension, your muscle link tension relationship going here, or it's not going to work. So they're
Yes.
not going to be able to lay on their back and recruit their abdominal wall and get their diaphragm going because it hurts. And because as you talked about, the visceral organs are being shoved into a diaphragm that's over recruiting and can cause all this phrenic kind of stuff in shoulder and neck and everything else. And they're not going to do that. It's uncomfortable and painful. So my thing is meet them where they are. I want them to really let go of the belly and get good at that. And then begin to, with exhale, gently draw that abdominal wall in just a little bit, not a ton, but they have to be at the right length tension relationship for that to occur. So they need to have a healing belly in order for that to happen.
Yeah. No, I was just going to say, so the first thing I do, and I did with this patient as well, is on hands and knees as well. It's the first thing right off the bat. Let the belly go. Everybody's an abdominal gripper these days. Like, okay, and we grip our abdomen, we grip our abdominal wall, and a lot of people are unconscious. A lot of it's conscious. So go on your hands and knees. Give you permission to let the belly go and do whatever type of breath work: apical, lateral costal, diaphragmatic. That's the first thing I do, and I also will put out there that I love the inversions. In my experience, I'm not going to say 100% of the time, but 90% at least, people with chronic low back pain, they have an overactive system, and their driver, at least in my population, is generally not their lumbar spine. It's in the thorax for the most part, or another region. The thorax is definitely in there, and or depending on the person's history. So there's another driver. But what do I do initially? I do like a down dog. I like those inversions, as well. And I do think that ultimately a lot of people, especially with thoracic, non-painful thoracic dysfunction resulting in lumbar spine pain, or even a radiculopathy, as is my patient, who we'll talk about at some point, you generally have an abdominal wall deficit. Okay, generally, what I do, and I think this is where you were going, you want to take out the overactivity first. And the best way to do that is go on their hands and knees so they can just let it go, quote unquote. So I like to use props. Sometimes I'll put people in supine. I'll put like something under their bum, because you want to take out that overactivity of whatever impairment you have found in your assessment, right? So, in order to, like, for example, if I have somebody in like a supine position, I'll put something under their bum, and I'll just have them do like a bent knee raise, just to see what their recruitment looks like. And more often than not, if you're really inverting them up a little bit, so their bum is higher than their head, they're gonna use the appropriate muscles with some resistance. They'll use like I'm thinking about the article you just talked about. Give them resistance at their knees. They won't recruit the overactive muscle, because by nature of the position, that muscle has been, quote unquote, taken out. The length tension relationship of that muscle in that position is such that it won't fire, or it will fire less. Does that make sense? Hope I made sense there.
Coordinated, in a coordinated
Correct.
fashion. So anyway,
Correct.
So what I do is with exhale, I have them draw the abdominal wall in just a bit. We're not talking about bracing. We're not talking about heavy, and we work on that until they get coordinated with that, with exhale. Once they get it and they can draw it in with exhale, then I have them keep it there as they take a nice inhale and exhale and inhale and exhale. What am I doing? I'm trying to reverse the muscle activity that's going on. So I want them to be able to hold that canister a little bit with gas, because that's what they should be doing, and getting that diaphragm to work as a pump muscle again. And once I get them to where they can do that, like leaning over a countertop or leaning, on hands and knees or whatever I want, because I want the belly to be in, relaxed with gravity coming down. I don't want it working against gravity yet. Once they get that, then I will have them sit up, and we'll practice that in sitting, where they can really let the belly wall go, and they can learn to lift it up, and they can learn to breathe. And if it's uncomfortable, we don't go in so far. You don't have to go in very far. People kind of get the idea that I can't teach my clients to do that because it hurts. And it's like, get them in a position where it doesn't hurt. This is why I say you've got to start where it doesn't hurt, and then begin to come in with it. and let it, and let it go, and get good at coordinating that with exhale. Use the breath to help you. If they can't get it with exhale, have them hum or something, because that's an exhale. So as
Yes,
you
yeah.
bring your wall in just a little bit, let it go. Play with them. I get them up into sitting. I have them stand with their back against the wall, and because it's easier to relax that, because their back, there's structure for their spine against the wall, so it's okay to mess with the abdominal wall and not, increase the back pain as much. It gets them into better positions to where they can actually learn to do it. And
Yep.
I ask these people to come in when it's going on. In other words, I don't want them on my schedule first thing in the morning. I want them
Right.
on my schedule at 4 o'clock on, because this is what comes on. This is the story
Yeah.
I hear. Sometime after lunch, I start getting belly cramps. It starts hurting, and then it all starts. I start getting that whole thing of bloating. I get gassy. I have to unbutton my pants. This is when I want to see them, because I can teach them this when, in the morning or whenever they're not feeling bad. All is great and wonderful, but it's not the same as until that gas is inserted into the colon.
Yeah, that's very interesting.
So you have to see them when that reflexive response is going to go off,
Yeah. Yeah. Yeah.
because it
Yeah.
doesn't matter if they can do it without that. It's got to happen during the throes of this dysenergic response. That's the only way to
Yeah.
change it. And this is something that I've learned with pelvic floor dyssynergia, with people who have difficulty moving things through. Again, we've got to get this whole canister and diaphragm thing going. But the other thing is that I can teach them that. I can teach them that and teach them that. But as soon as they have a real stool drop in from the inside, that response kicks right back up again.
Yeah.
And so
Yeah.
I need to see them when they have
Yeah.
needs.
I agree. Yeah.
So in pelvic health, this is why, for all of you who don't want to use the balloon catheter, this is why I use it. Because I can show a client who has like reversed their dyssynergia, they bear down, everything's fine, it all looks good. Put that balloon catheter in, put some air in their rectum, pull it down, and watch that dyssynergic response come back.
Yeah. That's
Now you
very
can
interesting.
train it. Now you can do it, because now it's relevant. And this
Yeah.
is what they're going to feel every time when they're trying to have a bowel movement at home. So now you can take that dysenergic response out and work with them on that. So
Yeah.
that's why you got to see these people when it's not good.
Yes. Yeah. Yeah. As with anything, right? Exactly. Someone has a problem running, run before you
Yeah.
come in my facility, right? But I wanted to add to that. So for people who don't do the balloon catheter, like myself, right? I'm not trained in that. So I have a lot of patients who come in and I'm really bloated. I like, we all have that, right? And you look at them and they've got this, thoracic sort of posterior translation. The belly is pushing out. And is it true bloating? Maybe. However,
Through distension.
true distension.
Yeah,
Exactly.
bloating
Thank you.
is the sensation. Distension is the
Is
GERD.
the right. And thank you. And so when you go in and you assess, and for me, a lot of times it's just normalizing the thoracic dysfunction, and the patient will look in the mirror and they'll be like, oh, my pressure belly's gone. And I'm like, well, yes, because it is how you're posturing yourself. And that could be many reasons why. It could be true GI dysfunction in there, or it just could be from a postpartum or just a common movement pattern.
Right.
However, so the difference between these people who may not have GI dysfunction, they still feel like I'm going to say the term bloated because that's the term they use, right? That they have a distended belly, but I'm bloated, and they think that it's truly a GI, and it may very well be. But I think from a non-pelvic health perspective, you want to make sure that indeed, they look in the mirror, and you need to sort of change the postural control first, or concurrently, and like you're treating the whole package, right?
Yeah, exactly. And part of that, like you talk about with the thorax and getting the thorax more mobile, is really working with the musculoskeletal system, the neuromuscular system, to not hold the diaphragm so tight, and to be able to let get the ribs moving again. And when you do that, the diaphragm is going to be free to move, and guess what's going to happen? It's going to reverse that pattern, and they're going to be able to recruit a little easier. They're going to be able to stand forward on their feet a little better. And, they're not going to have the same feeling, because now they're in a position for their diaphragm to help move things through, get the visceral system moving again. And it's not stagnant with this part being cut off by the ribs being shoved backwards.
Right. So are you saying, or are we saying in this episode, that to treat gas and bloating distension, to treat the diaphragm?
Yeah. 100%. 100%.
Yeah.
And because you're going to see the same thing as you see with chronic low back pain. And why is the diaphragm stiff? Because the erector spinae muscles are over recruiting.
Yeah.
And I've pulled on that thorax, and they're holding it and pulling it backwards because it's trying to maintain, stability. It's just it's trying to maintain the stiffness, the appropriate stiffness that it needs, and it's over stiff at that point.
And I guarantee you, 9 times out of 10, the patient will not make the connection. They may say, I'm coming in with back pain, and unless the therapist asks, any other symptoms in your body that, that may or may not be relevant? I'm like, yeah, a little bloating, some GI stuff. Okay, that's relevant, right? Some therapists don't ask that, okay? Because, for whatever reason, they're too busy. But I guarantee you, if you do ask a few of your chronic low back pain patients about their GI system, most of the time, there'll be something in that story that indicates that they are related, at least.
Yeah. And just for the final piece of this, I think what's really, if we want to take it down one more to a neurophysiological underpinning, anybody with chronic pain has an uptick in their central sensitization system, right? They're living off of cortisol. They're more anxious. They're more, there's the fear avoidance, the central sensitization, the tympakinesiophobia, fear of movement, all of those things that is encompassed in the SAD Cliffs, questionnaires. All of those are present. When we live in that state, we're continually telling our GI system, you're not relevant and we don't need you, because that's a survival system.
Yes.
And when we live in survival system all the time, we're going to run it. So these people with these chronic situations are going to have GI problems, not because because by the very virtue of the nervous system turning the GI system off, because when we're on high alert all the time, that's what happens.
Yes.
And so mobility slows down, we start getting constipated, and then it turns into kind of like this chronic thing, like I can't get out of it now, so that's kind of, if you notice, for some people after a crisis, there's usually a period where, they have to run to the bathroom because my GI system says, I got to go now, and it's like, because they've come down and now it's like, bah, we got to get all this done, but for a lot of people, it's, they stay at, if they come out of crisis, they never come all the way down. They're kind of just staying, and then they go back up into crisis, they come down, and go up into crisis and come down, but only maybe halfway, and eventually a third of the way, and eventually only a quarter of the way. Their nervous system needs, like you talked about it in the very beginning, they need to be really working on the things that will also do something very nice for them, which will increase their heart rate variability. And that's the quiet breathing, the mindfulness, all the different pieces that need to happen to really get them out of flight or fight and get them back in that social engagement, vagal nerve kind of where we live, where we're supposed to be living.
Yeah. And I think, just to wrap it up, I think people who have undiagnosed GI dysfunction, and once again, they've normalized it. And, GI, especially, I'm trying to think of the recent work I've read, like Crohn's disease, there's a high degree of percentage of patients with that. They have joint pain, knee pain, hand pain, back pain. They have arthralgia, myalgia. They've got it, and they don't make the correlation. And a lot of it is undiagnosed, and cortisol with Cushing syndrome, all of that. There is a feedback loop, and you don't realize how much someone is coming in and they've got chronic joint pain. Their histories and their timelines are like through the roof. There's a pretty high chance that there's been some GI system involvement at some point in that. That's been my experience. But I like the treatment aspect of this episode because I love the two studies. I actually can't wait to. I read the Kohler one. The other two I have not. But you know how well. Okay, so all's well and good, Erica and Susan. How do we treat these people? You know, so first recognize, right? Recognize, and then the diaphragm. I mean, we could do a whole episode on how to treat the diaphragm. Maybe we should at some point. Just positioning, and you know, it doesn't have to be patience, but it would be a great episode to do because it's not just the breath. Obviously, it's more, you know, more than that. So, but I love this episode. This has been great.
Remember that all of the nerves that go to the abdominal cavity, abdominal wall, all come from the thoracic spine.
Mm-hmm.
So
Amen.
We're all connected.
Amen.
From the bottom to the top and the top to the bottom.
Remember those splenic nerves?
Can't wait to hear from everyone. Please let us know what you think.
Yes.
And if you are interested in bringing one of your client cases to Tough to Treat, please get in touch with us at toughtotreatpt.com. No, at gmail.com.
Tough to treat PT at Gmail.
toughtotreatpt@gmail.com. One of these days I will get it straight. And drop us a line and let us know, and we'll see if we can't get you on the schedule.
Yeah, and also for the new listeners, if anybody, you know, and for the old listeners, thank you so much for listening. And for anybody who, you know, wherever you listen to podcasts, we would really appreciate it if you could drop us a review on, you know, wherever you listen, iTunes, Apple Podcasts, or wherever. It would really help us with the algorithm. And we also have YouTube as well. So it would be helpful if you could write even a 2-sentence testimonial on you know, for us. It would be most appreciated. We do read the reviews, and it's been very humbling, which is why we continue to do these episodes, because we find it so rewarding. So feel free to reach out, and see you on the next episode.